Welcome to this talk. This presentation is part of a larger program on building capacity in implementation science research and practice in low and middle income countries. This project is funded by a grant from the National Institute of Mental Health, which is part of the U.S. National Institutes of Health. These presentations on implementation science and measurement are specific to working in areas with few health resources. If you have more questions, you can find more information on our group's website, including more information specifically about this study. We hope you find this work useful.
Thank you for joining our webinar today on measurement of implementation outcomes in low and middle income countries. My name is Laura Murray. I'm on faculty at the Johns Hopkins Bloomberg School of Public Health in the Department of Mental Health. I'm a clinical psychologist by training and have been doing implementation studies since my postdoc years. I'll be presenting today alongside my colleague, Dr. Emily Harrows.
Thanks, Laura, and really glad to be here with all of you. I'm an assistant scientist in the Department of Mental Health at Johns Hopkins Bloomberg School of Public Health as well, and I focus on research methods for implementation science in low-resource and global contexts.
So here we have an applied mental health research group, a multidisciplinary group that focuses on mental and behavioral health in low and middle income countries. We do a number of tasks such as qualitative ethnographic work, validation of instruments, randomized clinical trials, and implementation research all over the world. For example, in Iraq, Cambodia, Zambia, Myanmar, and many other places. These projects span a range of topics, such as gender-based violence or violence in general, child sexual abuse and HIV, internally displaced persons and veterans, victims of torture or political violence, and on and on. Please take a look at our webpage to understand more about the breadth and depth of our projects. For today's webinar, we will be talking about measurement of implementation outcomes in low and middle income countries. We hope that some of you were able to see the first part of this webinar series that introduced implementation science in global mental health. These webinars are funded through a National Institute of Mental Health research project our team is currently running on implementation science in Myanmar, with a focus on capacity building. We will talk a bit more about this project towards the end of this presentation as an example of how we are using the implementation science measurement in it. So as I said, we presented a webinar on the basics of implementation science. This webinar today is a follow-up to that and will focus on how we measure important constructs within implementation science. Here is a brief outline of what we will be reviewing. The background and what constructs we will be looking at, existing measures from high-income countries, challenges with measurement. Then we will move into measurement within low and middle income countries and how we developed a measure. Finally, we'll talk about the use of this measure and next steps. So let's begin with a background. Despite robust evidence on the benefits of many healthcare programs in low and middle income countries, there is a significant gap between what is found to be effective and what is done in actual practice. Over the past 20 years, the researchers in global mental health have repeatedly demonstrated the effectiveness of services to treat mental health problems in low and middle income countries. Despite this progress, wide scale-up and sustainability of such evidence-based programs is virtually non-existent. The field of implementation science has coalesced over how to bridge this gap. However, there are significant gaps related to measurement issues that are critical to advancing implementation science efforts. Without high-quality measurement, it is impossible to study the process of implementation and the effect of implementation strategies for mental health in low and middle income settings. Our Applied Mental Health Research Group has spent the last 20 years pushing to understand and develop ways to measure mental health symptoms and syndromes in a wide array of low and middle income country settings. We set out to use that experience and apply it to measurement of implementation outcomes across a diverse range of settings. There are many different frameworks within implementation science. some that we touched on during our first webinar. Here, we will review the framework that we focused on that are most relevant to global mental health. One that we began with is Dr. Enola Proctor's. And here you see the implementation outcomes. We will talk more about these as this webinar goes on. Here is a closer look at the definitions of some of the outcomes we began focusing on. You see here how the field is trying to operationalize these outcomes. These definitions are critical because they guide items that would measure each of these constructs. So, for example, you see here adoption is operationalized as the intention, initial decision, or action to try or employ an innovation or evidence-based practice. We will talk more about how we further operationalized each of these constructs for low and middle income countries, but we wanted to give you all a sense of what outcomes we were talking about. Here we highlight 2 recent reviews published on the measurement of implementation science and the number of instruments they identified. You see here 104 and 130. There are many, many instruments out there. It is evident that even within the United States and other high-income countries, there is a significant amount of work being done on reviewing and trying to harmonize measurement within implementation science. Part of what we wanted to do in this webinar is give you some resources. These are resources that are available regarding measurement within implementation science. This Grid-Enabled Measures, or GEM, portal was created by the National Cancer Institute to support behavioral and social scientists and other stakeholders as they advance their research and clinical practice. Here is just a shot of their website. GEM is an incredible resource. It includes existing measures, their use, psychometrics, if they're available. You see here that they have uploaded measures and they have many, many people downloading them. Another resource we wanted to share with all of you is the SIRC Instrument Review Project. SIRC standing for Society for Implementation Research Collaboration. They have spent many years reviewing and synthesizing instruments that evaluate dissemination and implementation research constructs. Here we have a web link for you and encourage you to check this out. Here we wanted to show you an example of what you will see if you move further through the SIRC instrument website. These are all examples of the many different measures that solely look at implementation climate. So they define implementation climate as the absorptive capacity for change, shared receptivity of involved individuals to an intervention, and the extent to which use of that intervention will be rewarded, supported, and expected within their organization. Now, I don't want you to feel like you have to digest all of this data on your screen right now. Our main point in showing you this is so that you see an example of the great work SIRC has done to consolidate data and research in a way that is helpful in understanding and learning about measurement of dissemination and implementation research constructs. Something like this could help you know what measures exist and the psychometrics behind them that would help you make choices with what instruments you may choose for your study or project. Despite the vast number of measures that are out there, there are many challenges with how to assess implementation processes and outcomes. These are well documented in the literature now, with these really existing in the field overall. Major challenges include varying definitions of outcomes across frameworks. For example, leadership might be defined as specific to leading an implementation effort or be more general about characteristics of leaders. Second, most studies often use their own measures or indicators, meaning there is little overlap between projects. Third, many measures focus on only one construct. For example, an entire measure only on leadership, or an entire measure only on organizational culture, and almost all focus on only one stakeholder level. Stakeholder levels play a role in implementation, and it's really important to look across all of those levels. Fourth, Many measures are quite long. For example, the organizational readiness for change measure is over 100 items and still looks at only one construct. So what happens with long measures? Well, participants and respondents often get very tired and fatigued. They may answer incorrectly, and it's often challenging for programs to implement. Fifth, there has been very little rigorous testing of measures. So how do we know if they're really valid or really measuring what we think they're measuring? Are they reliable measures? Or in other words, are your results on measures consistent over time? Finally, with different items, definitions, and domains, it is very hard to pool data across studies, which makes synthesis across studies challenging. And this is an important way to move fields forward. So in global mental health specifically, we face even more challenges. When we started this process in 2011, there were no existing implementation measures that had been studied in low and middle income countries. Most of our participants have never been exposed to mental health services. This is often true at the organization, provider, and consumer level. Task shifting, or the use of lay or non-specialist counselors, means that few have been exposed to other ways to implement mental health services. This makes it challenging for assessment, as without exposure to variation in implementation, it is very hard for them to judge the degree to which a program is well implemented. One of our biggest challenges is that the field of implementation science has largely been based in Western contexts where mental health systems are in place. However, we are often working in places where these systems don't exist. So, for example, there are no centers that offer mental health services. There are no social workers, psychologists, or psychiatrists. Finally, many of the items on existing measures are irrelevant to lower resource settings. For example, items related to ongoing educational credits, professional organizations, and insurance reimbursements and billing often don't relate to the settings we work in.
So measurement is fundamental to science. It has been quoted that science is measurement. Without careful attention to measurement and implementation science in global mental health, what we risk doing is akin to building a magnificent house without a solid foundation. The science will collapse if our measures are not solid.